Well, good morning, everyone. I'm Dr. Jim Allen, and I'll be moderating today's COVID health and wellness briefing. The purpose of these briefings is to give members of the media direct access to some of the COVID-19 experts at The Ohio State University in order to help support and enhance statewide communication efforts with science and medical information. In order to ensure that all of you have an opportunity to ask your questions to our medical experts, I'd like for you to use the raise hand function on your Zoom meeting window, and I'll call on each of you in turn after some opening comments from each of today's experts. If you don't already have your name and outlet listed on your Zoom ID, please go ahead and do so we know who we're calling on. When the question and answer portion begins, you'll need to unmute and start your video when prompted so that we can hear your questions. Now, let me introduce today's panel. Dr. Andrew Thomas is the Chief Clinical Officer for the OSU Wexner Medical Center, as well as the Regional Representative on Pandemic Response. Dr. Nicholas Kaman is a Professor of Emergency Medicine and leader of the OSU Scarce Resource Allocation Group. Ryan Haley is an Ambulatory Services Administrator and the leader of the medical system's vaccination efforts. Dr. Peter Moeller is the Chief Scientific Officer of the OSU Wexner Medical Center and the Vice Dean for Research at the Ohio State University College of Medicine. And Dr. Dan Jones is the Vice Chair of the Division of Molecular Pathology at the OSU Wexner Medical Center. Now, at 11 o'clock, we're going to be discussing some important new discoveries about the COVID virus in Central Ohio. We'll have additional media representatives joining us. So we will be extending our time today for an extra half hour for a total of an hour to 11:30 a.m. In opening up our discussion, let me first ask a question to Dr. Thomas. What is the latest on the COVID cases and hospitalizations here in Central Ohio?
Thanks, Jim. I apologize. It took me a second to unmute there. I am going to go through a quick review of where we are in terms of COVID census. As many of you know, the state is broken up into 8 different emergency management regions. Zone 2, as we talk about, is the Central Ohio region there in orange, as well as regions 7 and 8 down in southern and southeastern Ohio. I serve as the lead for Zone 2, and I'll share some data with you for our local zone and a little bit about our Ohio State data. This is data that looks since back in April at hospital census on any given day for 3 data elements, one being total COVID active patients that are in the hospital. That's the blue line at the top. The red line are active COVID cases that are in the intensive care unit across the Zone 2 hospitals. And the green line are active COVID cases that are on the ventilator across the zone's hospitals. As you can see, since mid-December, we've seen a nice trend downwards in terms of the blue line. That's the total number of patients in the hospital. We peaked in the zone at around 1,200 patients, and we've now been down under 900 patients for 11 of the last 12 days. I think all the work that was done, certainly by the media as well as through a variety of outlets, from the governor's press conferences to letters to the editor to ads on TV, really expressing to people the importance of staying put over the holidays, not expanding their bubble greatly. I think a lot of that has really paid off. As many of you know, other areas around the country are not seeing this trend. They're seeing significant increases in that post-holiday hospitalization. And in general, the southern, or I should say Zone 3, the southwestern part of the state, is a little higher in terms of compared to where they peaked back in December, but they've certainly not extended past that. And Zone 1 up in northern Ohio looks relatively similar to our curve. Now, the good news is we're down from 1,200 patients. The bad news is if you look at where we were peaking back in the spring, we're still over double what our peak was back in the spring. So it's still a very high number. And what we see coming out of the holidays when we do our daily surge calls with our regional hospital partners across Zone 2, many of them are seeing that kind of normal return of hospital operations coming out of the holidays and still having a very high COVID census. But we've gone in the state now down in terms of that crowding out effect we talked about. Currently, as of data through Monday, 1 out of every 5 patients in the hospital for any reason in the state of Ohio is an active COVID case. That's up from 1 out of 4. So it's actually improving, or I should say down from 1 out of 4. For ICUs, it's still 1 out of 4, and for vents, it's still 1 out of 3. But the numbers are all showing a shift to a little bit less of a crowding out effect in our hospitals than where we were a month ago, which is the right trend. Here at Ohio State, actually, our curves look kind of relatively similar in terms of shape. We're seeing a decrease in our numbers since mid-December, and certainly seeing a decrease in our ICU numbers. That's very, very beneficial as we look to manage other patients who come in with strokes, traumas, heart attacks. We need to have room in our ICUs to manage them. So it's really a nice trend to have, but we're hopeful that it will continue and we won't see that post-holiday surge that other parts of the country are seeing.
Dr. Thomas, the COVID vaccinations began here on December 14th, and the Wexner Medical Center was one of the first in the state to begin vaccinating employees. Where do we stand overall?
So far, Jim, the individuals that we've been vaccinating have been our healthcare personnel. So those are frontline staff that work in our ERs, our intensive care units, our staff that work in our med-surg units, and then a lot of our staff, for example, in radiology or transporters, environmental service workers that clean patient rooms. We're looking broadly across our populations, including our interns, residents, and fellows, and our medical students and health science students broadly. So through data through yesterday, we vaccinated now 10,569 individuals with their first dose. We have an additional 5,000 individuals that have been invited and have already signed up to be vaccinated in the coming days. So we're really excited about that number of individuals being vaccinated. And the other key thing to note is because we were a Pfizer site in that original pre-position site, we had vaccine both a week early compared to the Moderna outreach or the Moderna supply. In addition, that's a 3-week turnaround time for the second dose. So we've actually already provided 994 individuals with their second dose of vaccine. That was mostly completed last week, which was 3 weeks beyond the original Pfizer allocation.
Well, thanks, Dr. Thomas. Our next question is for Dr. Kaman. Could you briefly explain how we prioritize this initially very scarce resource for our workforce, and then how we're shifting to focus on vaccinating the public?
Yeah, so thanks for that. Throughout the pandemic, many things have been in short supply, like PPE, and then the treatments that come out like remdesivir and monoclonal antibodies. So disaster planners really need to look at how to maximize the benefit of these scarce resources as they come. And each state does this differently. So the state of Ohio chose to prioritize frontline healthcare providers and nursing homes with the first allocation. Much of the first week's dose went to the nursing homes. So we were really having to focus on who could we maximally benefit with that scarce resource. Our group looked at our intensive care units, our emergency department, our respiratory therapists, and we looked at the data of where people come into contact with COVID, and we prioritized those groups. But as we got more supply, we're keeping up and we're getting that vaccine into arms. So we're going through the vaccine we got last week, and we'll start on the vaccine this week. And we've started to move now towards people that support the critical mission of our medical center. So it may not be somebody who works in an intensive care unit, but it may be somebody who works the call center, or somebody who, if they weren't here, we wouldn't be able to respond to the pandemic. We will finish our frontline healthcare workers, our 1A allocation this week, and we'll be moving towards the 1B allocation per the state, which is adults 80 and over, starting on Tuesday.
Well, how will patients know that it's their time to get vaccinated?
Well, we plan on reaching out to our patients through the MyChart and through the health record. And we also hope that our providers, our primary care providers and others will reach out to their patients as well. There will be information given out through the different health department websites. So I think the hope is to get the information out to patients through multiple channels.
Thanks, Dr. Command. Next question is for Ryan Haley. We'll be using the Schottenstein Center, is my understanding. When somebody arrives at the Schottenstein Center to get vaccinated, what's going to actually happen with them?
Yeah, thanks, Dr. Allen. Good morning. So for folks that are arriving at the Schottenstein Center, it'll be similar in terms of the process that we utilize today for our existing vaccination sites. So for individuals that have scheduled via MyChart or the online portal, they'll get a notification about their arrival time. And we're really hoping individuals arrive close to their appointment time. We're asking people to arrive 5 minutes early because the check-in process is rather seamless. So they'll check in at the information desk and get a couple of sheets of paper and be escorted over to their vaccination site. We'll be requiring masks and everything internally as you would any other ambulatory clinic. Once they're navigated over to their vaccination site, one of our vaccinators will walk through a list of questions with them, provide a consent form, and then administer the vaccine. And then after that, they will be waiting there for a matter of about 15 minutes, where they'll be monitored by a health professional, and they'll receive their vaccination card. During that monitoring period, we'll make sure that they're scheduled for their second dose appointment so that they know exactly when and where that'll occur, so they have that done before they leave the facility. And then they'll be on their way. We really hope that the process is, so far it's been seamless at our other sites for our employees, and we hope that continues at the Schottenstein Center. It's really a matter of about 30 or 40 minutes tops, depending on flow and timing. We have a number of people that are going to be escorting patients about because the facility is going to be, a lot larger than our current sites. But we've got a really strong team that's being assembled so that we can ramp up to maintain our volumes. As Dr. Command stated, we're working through each week of distribution, allocation, and working through it.
Well, thanks. In about 15 minutes at 11 o'clock, Dr. Moeller and Dr. Jones will be covering some important breaking news about a new SARS-CoV-2 variant. But first, I'd like to take some questions from our media colleagues about the COVID vaccination before we get into that additional information. And if you do have questions, please either use the raise hand function on Zoom, or you can also just type in to the chat function that you have a question, and I'll call on each of you. Ryan, what makes the COVID vaccination different from just a regular flu shot or pneumococcal vaccine shot that somebody might get at the regular physician's office or at the grocery store or drugstore? Why is this different in terms of the logistics of getting people vaccinated?
Yeah, thanks for that question. I think, the storage process is obviously different. When you have to store the vaccine at ultra cold temperatures, it becomes a big logistical challenge to get that out into the community, into our smaller primary care sites where we might not have the ability to vaccinate as many people. Also, space becomes a rate limiting factor. If we have to monitor individuals for 15 minutes, we have to maintain physical distancing. It becomes very difficult to bring a lot of people through a primary care office that might have 15 to 20 exam rooms. When you look at a location like the Schottenstein Center, and we're going to be using 2 concourses there, the north and the east concourse predominantly, we'll have over 150 stations that are nicely spaced out, physically distanced, so that we all feel comfortable and we're not doing anything to put anybody in harm's way. So we have the ability to do more at a site like that. I think the long-term hope is that we are able to get this into our primary care offices, and that's a discussion that we're having ongoing in terms of our planning process over the next couple of months.
We have a question from the Columbus Dispatch. I believe it's Max Philby. Is that correct?
That's correct. Thanks, Doctor. Hi, everyone. I had a question regarding kind of vaccine distribution in general.
Max, we lost you there.
Obviously, can you hear me now?
Yeah.
Yes.
Can you hear me? Sorry.
Now we can, yes.
I had a question about sort of vaccine distribution in general. Was wondering what you all make of some of these no waste lists or spoilage lists we're starting to read about, and why or why not that might be a necessary thing to do with vaccine distribution.
Ryan, I'm going to start off directing this to you and then have it follow up with Dr. Kaman. Tell us a little bit about the number of doses in the vials and how long you can keep those vials after you first open them.
Yeah, thanks. You know, this has obviously been something that's been very important to us, and I think we've had a really good plan and have been very fortunate not to waste any vaccine in our process. So with the Pfizer vaccine, you know, those are 5-dose vials, and once those vials are open, we have roughly an hour to make sure that we are getting that vaccine into the arms of our patients. So we've worked through the process in terms of scheduling and trying to strategically schedule the right number of individuals. But as natural things happen, you know, some people can't make it to their appointment, or something comes up where that number does not always come in an increment of 5. And so we've had the ability to kind of call ahead to get one of our folks who've already been scheduled out either the next day or the day before to come in early, or even vaccinating some of the workers on site who are also on the list. So we've been really in a good rhythm of making sure that that vaccine gets into the arms of the frontline healthcare workers, and we're not wasting a single dose.
Dr. Kaman, anything that you want to add to that?
Yeah, no, I would just second what Ryan said. I mean, we're the stewards of a very scarce resource that's given to us from the state. And, you know, we've really had a lot of conversations about not wasting a single dose. We're trying to serve, you know, underserved populations and mitigate inequity. So, you know, if there's doses left at the end of the day, we, you know, call over to, you know, the emergency department or a place, and we get people who have been invited based on their risk a dose of the vaccine. But we are not wasting any vaccine. It ultimately serves the public to get these vaccines into people because it'll stop the spread of the virus. So we've worked to make sure we do that at all costs.
Thanks, Dr. Kaman. Let's next go to Pete Grieve from Spectrum News. And Mr. Grieve, I think you may be on mute. So we'll come back to Mr. Grieve in just a minute. And next, we're going to go to Liz Bonis.
Hello, good morning. Can you hear me?
Yes.
My last name is Bonis, by the way, but thank you. I went through KRC TV in Cincinnati, and yesterday we heard that Alex Azar suggested that we open up all the vaccine doses, not hold back the second dose. And so I've been asked now if you think there is enough production, will people actually get the second dose, and what happens if you wait?
Dr. Thomas, you want to address that?
Yeah, I'd be happy to take that question. I think none of us on this call are experts on vaccine supply chain and production. That being said, we've had some of the similar discussions with the Ohio Department of Health around this issue, and they feel like they've been given an assurance at this point from the federal government, who really does have the best eyes on the situation, that because of the vaccine that is in production and that production that's expected, that there should not be problems with limitations on vaccine for second doses. But I think that there's still a lot to be understood about exactly how HHS is going to be doing this. But ODH has been working with the federal partners, and they're probably the best place to ask that question.
So do you expect to do that at your location?
Expect to do what?
To hold the doses, or to just let them have enough of them and continue to give everybody and not worry about whether or not they come out or whether or not there will be enough?
So obviously at this point, this was just announced yesterday. So there's still more learning to do, but we have been, as of a call last night, assured by the state that they do not think we will need to do that. To hold back second doses on our part and inventory and keep those in our storage. Like I said, the state is working with the federal government to really define exactly how that whole process is going to work.
Thank you.
Well, let's go back to Pete Grieve, if you're able to connect.
Yeah, can you hear me now?
Yes.
Okay. I'm wondering if you guys are looking at like pre-registering for schools, or if you could comment on school staff and when they might be able to get the vaccine, and how the learning model, whether that's hybrid or fully in person, might play into that.
Dr. Thomas, you want to take that one?
So the state obviously is overseeing that process. They have not released the final, for lack of a better word, regulations around how that's going to work in the process. They're looking, I believe, at early February to kick that off. So I would recommend that question go to the Ohio Department of Health. We have discussed potentially participating in that program. At this point, our focus is really around our elderly patients in the 1B group until we really understand the size, scope, and scale of what they need us to do. But we'll consider participating in that once they have it a little bit better defined.
Thank you. We're next going to go to Melissa Voetsch, and I apologize if I mispronounced your name.
No, absolutely. That's fine. Melissa Voetsch from 13ABC in Toledo. Thank you very much. I guess this speaks to vaccine availability to the point just a couple minutes ago, but is there any flexibility to your knowledge? Obviously, clinical trials were done with the first shot being given and then the second 21 days and 28 days later, respectively. Is there any flexibility to give the second dose earlier or later, and is it just as effective? I think this may become an issue as we talk about the availability of second doses down the road.
Yeah,
Nan, you want to take that?
I can take that. Yeah, so, the guidance from both of the companies, Moderna and Pfizer, say that there's a window that you can give the second dose. But if for some reason you can't encounter that window and the shot is delayed, that you give it at the soonest availability that you can give it. And as you can imagine, after one dose, people can contract COVID, so they might be in quarantine, they might be in isolation because a family member had an encounter. So you have to wait 20 days after infection to give the vaccine. So we're anticipating that we'll need to be flexible with the second dose. And what we'll try to do is just give it at the soonest availability that patient has to give the second dose. We are trying to stick to what was studied in the clinical trials because that's how we know the vaccine functions the best. That 95% efficacy was at these specific time intervals. But, we're in the middle of a pandemic and we know that we have to be flexible.
I think, Nick, it's also important to recognize that one of the elements of our process that Ryan laid out before is when you're in that observation period for the 15 or 30 minutes after you've received your vaccine, that's when we come around and schedule you for your next vaccine dose. So we have really good eyes on the future schedule for those second doses moving forward. As we try and manage our capacity and ramp up our capacity, that's going to be an important step to have eyes on that transparent data.
All right, next we're going to go to NBC4, Alan Henry.
Good morning. I was wondering if you could just kind of go over the logistics of the vaccine distribution to the public at the Schottenstein. And you mentioned the My Chart and the notifications. Is it just people within the Western Health System, or how are you going to, so people don't just show up next week and expect to get vaccinated? How is that going to kind of all roll out?
Ryan, you want to take that?
Yeah, I can take that question. So thanks for asking that question, Alan. First we're looking at our existing employees, or existing patients rather, patients who have had a visit in the last 3 years. And so basically their records are going to be identified as ready for vaccine. And so right now the 80-plus-year-old population has actually started scheduling their appointments for next Tuesday. So starting next Tuesday, the 19th at the Schottenstein Center, we will be, hosting vaccination efforts for the 80-plus-year-old population for patients who are existing patients from our primary care and specialists here at Ohio State. So we're really excited that they're picking up on those notifications. We have a number of, in addition to what Dr. Kaman indicated earlier, we have My Chart messages. We'll have some email messages that will go out. We'll actually have an outbound dialer effort. We're going to need to spread those out because we don't want to overflow our phones so that people can't get through, but we're going to reach out to them so that they can connect with us and schedule their appointment. We know that there's a multitude of ways people are comfortable with scheduling. And so our primary care offices will also have access to make those appointments as well. So we want to be as convenient as we can. We know that that might not touch everybody, but we hope that of the thousands of people that fall in that 80 plus category, we get as many as we possibly can. There'll also be paper mail. I know that that's obviously a much slower form, but that's sort of the last resort. So people who are part of that category of patients know that they're eligible and have a way to schedule that appointment.
I think, Ryan, it's also important to note that the other health systems in town, as well as some of the physician practices, will be providing vaccine. The health department is still providing vaccine. And also, it's my understanding that retail pharmacies in the area will be providing the vaccine. Obviously, each one of those sites has a different volume per day that they'll be able to do. The Ohio Department of Health will be putting out a website. I believe it's supposed to come up this week. That's actually relatively similar to the Where Can I Get Tested website that they put up back in the spring, that will highlight vaccine providers based on your zip code and then push people to one or the other. But we are highly recommending, and I think this is true for all the hospitals in the state, that if you do want to get your vaccine, to try to use your routine healthcare provider as your first choice in doing that. So it's just a lot easier in terms of the scheduling, the documentation, and the orientation of the patient to get them into a provider network that they're already familiar with and they're a known entity in.
Dr. Kamen, Ohio State was one of the first in the region and in the state to give the first dose of the vaccines, and consequently, we've also been amongst the first to give the second doses. There's been a lot of discussion about side effects of both the first and the second doses. What's been the experience here so far in terms of side effects of the first and the second doses?
Yeah, so, those things that, people refer to as side effects are the reaction of your body making antibodies to that spike protein. So, we see these as positives that the vaccine is working. I've been fortunate enough to get my second dose and had a sore arm, but didn't have some of the systemic muscle aches or fevers that some people had. In the studies, there were some incidents of fever, and if we're seeing fevers in people who get the vaccine, we do have them stay home from work, but most people have a very mild reaction. So we've given, almost 1,000 second dose vaccines, and we're seeing very few fevers and things like that. So what we do is, we monitor those things, and in almost everyone, they're gone by 24 to 36 hours. So small price to pay to have a healthcare force that's vaccinated against COVID-19.
Okay, one final question before we pivot to talk about some of the new discoveries of the COVID-2 virus here in Central Ohio. Dr. Thomas, can you update us with the monoclonal antibody program that's been going on?
Thank you, Jim. Yes, we're quite excited. I think we've discussed this in past on these media briefings. In mid-November, the Eli Lilly monoclonal antibody product received FDA emergency use authorization. And since that time, the Regeneron product has received the same EUA approval. So we are actually able, with the federal guidelines about who the drug can be used in, we've been able to really ramp up quickly a new infusion site at our East Hospital. Dr. Allen himself was an integral part of getting that set up within a week's period of time. It went from an educational conference room auditorium to a patient care space, really rapid transformation over the Veterans Day holiday week. We now are approaching, and it'll probably be end of tomorrow or early Friday, our 1,000th infusion of of one of the two monoclonal antibody products. We're quite excited about that. When you look at the data and the evidence for patients at high risk for severe disease, high risk for hospitalization, that's what's defined in the EUA based on age and comorbidities, other illnesses that the patient has. Those medications have a significant ability to reduce the need of those high-risk individuals to be admitted to the hospital. We would like to think that's part of why at least our inpatient census numbers have come down. It's probably one of many reasons. Certainly compliance with masking and distancing and all those things that people did right over the holidays is part of that as well. But for the data I showed at the beginning, We do think that having now infused 1,000 patients here later in the week with monoclonal antibody, that we've reduced a significant number of hospital admissions with that effort. So we're strong believers in making sure those high-risk patients get assessed and get treated as quickly as possible with the monoclonal antibody.
Well, thanks, Dr. Thomas. For
Jim,
the next portion of our session today, we're going to be reintroducing two additional experts. First, Dr. Peter Moeller is the Chief Scientific Officer of the OSU Wexner Medical Center, and he's also the Vice Dean for Research in the Ohio State University College of Medicine. And Dr. Dan Jones is the Vice Chair of the Division of Molecular Pathology at the OSU Wexner Medical Center. Well, Dr. Moeller and Dr. Jones, you've just made a couple of significant research discoveries. First, a new variant of the SARS-CoV-2 virus, the virus that causes COVID-19, that is similar to other strains identified in the United Kingdom, but likely arose from a strain already here in the United States. And secondly, the evolution of another U.S. strain with 3 gene mutations that we haven't seen previously in the SARS-CoV-2. Break down this for us, and what does this actually mean?
Yeah, maybe I'll take that question. So basically, these are 2 separate findings. They were both derived from genomic sequencing of nasopharyngeal swabs from positive patients. And in the first case, we, like all labs across the U.S., once we heard about the distinct UK and South African strains, went looking for those viruses in our patient population. And instead, what we found was, as you mentioned, a new variant that contains the mutation in the spike protein that is in common between the United Kingdom and South African variants, but is on a backbone which we think is a US-derived backbone, either locally or across the US. And so this has important implications for whether or not travel restrictions would be effective in limiting the spread of viruses with this particular mutation. So it has the mutation in common with these 2 strains, but is a different strain backbone that is based in the US. So that, we think, is one of the important implications.
Do we know if this is going to affect vaccines and treatments that we currently are using for COVID-19?
Yeah, so it's too early to tell. I think this is a mutation that affects the receptor binding area of the spike protein. And there is some limited science from other groups showing that it can interfere with antibody binding, but we do not yet know enough to know whether the cocktails of antibodies that are present, which contain more than one antibodies to against more than one site, would be affected by this particular mutation.
Dr. Allen, if I could just add to that, I think it's worth the public understanding kind of how these vaccines work, and that while we're talking about a specific amino acid variant or mutation, this is in context of a very large protein. So if you think about the size of this spike protein that we talk a lot about, and this is this piece of the virus that literally latches onto the cells and allows it to get in, is about 1,300 amino acids. And in fact, when we develop these vaccines against COVID, that's what they're directed against, very large regions of this spike protein. So think of it almost like Velcro, right? So if you had a whole bunch of different pieces of Velcro and they're sticking together, if you take 1 or 2 of those off, certainly it's going to weaken the Velcro, but the Velcro is still likely going to work. And that's the data that we've seen so far for some of these variants. Now, some of the things that we're thinking about as scientists across the world is, if you continue to have variations or mutations in these, at what point do we start having an impact on that Velcro? Or at what point do we start having an impact on things like some of the monoclonal therapies? And these are things that we want to understand. So I think it's important for the audience today to understand we're not ready to overreact. We want to make sure that we study these in the lab, that we get really good data, and that so far we know that our vaccines are very likely effective against this variant as well. But it's important that we keep our eye on these.
What's the significance epidemiologically or otherwise about these now 3 variants arising in the last couple of months from the UK, South America, or South Africa, and now Columbus?
Yeah, I mean, I think one of the interesting things about the genomic surveillance of SARS-CoV-2 is that we saw very early on in March and April the shift to the so-called G strain, which had a substantial impact on the spread of this virus. But since that time, the virus has been very stable. And so one of the things that's very interesting about our finding and the findings from South Africa and the UK is that we are now in a period where the virus is changing quite substantially. So this is why we're concerned, and it links the two findings that we report today. So the second finding we report today with a strain with 3 additional mutations appears to be taking over in the local population. So once again, it suggests that maybe there's mutations that affect the transmission of the virus, not necessarily the disease or vaccine response, but at least the transmission, the ability of the virus to spread in the population.
So we're really dealing today with 2 different breaking news information about the virus. How concerned should we be about these 2 findings?
Maybe I can start. So I think since the COVID crisis started at the Wexner Medical Center, and I would say really across the world, scientists have really been trying to look forward to be able to make sure that as we design new diagnostics and design new therapeutics, that we have good line of sight of what's happening. And so all along we have been looking for, variations, and this is very normal for a virus to mutate. So I don't want to put in, this is not a new finding. Viruses do mutate. I think what we want to make sure is that we respond with good data and with data that supports what these findings show. So I think what we want to be able to say is, we have in the United States a finding today that suggests that this UK version didn't transmit over likely a plane or a boat, but actually was a spontaneous or natural mutation on an US strain that happened here likely in the United States over the course of the last 6 to 8 weeks. And again, that's more data that we need to show. I think the other thing that we want to do is to get further ahead. And what does that mean? It means to sequence additional people, not only across Central Ohio, but really around the United States. If we believe from a public health standpoint that these are more infectious, that these may cause more severe disease, which we don't have data on yet, we need to be able to combat that. And that's a lot of masking, a lot of distancing, but also understanding, again, how are we diagnosing the virus and how are we treating the virus.
Let's go to some questions from our media representatives. First from CNBC.
Yeah, can you guys hear me?
Yes.
Excellent. I was just hoping to get a little bit more clarity on the strain that with the 3 gene mutations that you guys believe is now becoming or is dominant in the Columbus area. Could you provide more details on that? It was a little confusing in the release, the distinction between the 2 findings. Which strain is the one that you guys have named COH20G? That one, if you could just clarify which one that applies to.
Yeah, so there's a terminology that's being used internationally to look at the different major branches, strains of the virus. So both of these findings relate to a US-based strain called the 20G strain. But there are differences besides the core elements of the 20G strain. So we think both of these look like they arose from US-based strains. And we say US-based because the vast majority of the occurrences of this 20G strain have been reported by laboratories sequencing samples in the US. So that's our evidence that these are US-based as opposed to based in other areas. So they are both out of the same general strain. We can consider them as having some sub-strain changes in addition to the new mutations that we report today. So they are different findings from viruses that are similar but not identical.
Let's go to NBC News, Jane Weaver.
Hello, can you hear me?
Yes.
Okay, you may be aware of a report from the White House COVID task force to the states last week. They were expressing concern about a new U.S. variant. Is this what the task force briefing, the task force report was concerned about? And the second part is, at the time the CDC said they had no evidence of a new U.S. variant. What's your response to that? Have you been in touch with the CDC? Thank you.
So we have presented our findings yesterday to the High Department of Health. So There are multiple things happening. So this is a moment in time when lots of different things are happening with the virus. So we have had reports from 7 or 8 states of detection in the US of the actual UK strain virus. Okay, so those are what those reports concern. And then in addition, we're reporting today the emergence of a identical mutation in the spike protein in a different strain of virus. So we're actually talking about multiple different things. And so I think to reinforce what Dr. Muller said, this is not surprising that we're seeing this, but we're reporting it today because it has important implications when one is thinking about surveillance for these mutations and travel restrictions related to these mutations to understand where these mutations are arising and strains that might be circulating community-wide in the US for months before the detection of the UK variant.
And Dan, just to make clear, you and your team have been doing genetic analysis on the virus since back in the spring. This isn't something you just started last week in response to comments from the CDC or the White House Task Force, but it's similar. This is what they were this type of thing is what they were talking about when they were worried about US variants. But this was not known last week at the time anyone from the White House Task Force would have made a comment about that.
Right. Obviously, we're seeing changes from day to day. Different states are reporting different viruses emerging. And just to emphasize that these are common mutations occurring in different strain backgrounds. So that's telling us likely these are independent arising of the same mutation in different places.
All right, let's go to Alexis Moberger from ABC6.
Sorry about that, just trying to unmute. So as far as with this new strain, is it more contagious and why is that? And then you also talked about travel restrictions. Is that something that we could see just in Columbus or the state of Ohio as far as not trying to travel in and out? What can we kind of expect with that?
Yeah, I think it's important to emphasize, as Dr. Muller did, that we're in the early stages of understanding how prevalent both of these new variants that we're describing are. In the first case, the one that is the shared mutation with the South African and UK strain, we have only identified a single sample with this mutation. In the second case, the thing that's concerning us a little bit is that over the course of the last 3 weeks, we are finding the virus with the 3 additional mutations more commonly in patient samples, and that suggests that it may be more able to spread or be more transmissible. But lots of work needs to be done, and I think the comment on travel restrictions is mainly to indicate, obviously, if a virus is already present in the United States in a common strain, that changes the interpretation of whether travel is a relevant factor in the spread.
Okay, thank you.
Let's go to Elia Williamson from WDTN.
Hello, thank you. Can you all hear me?
Yes.
Okay, Aaliyah Williamson, WDTN in Dayton, Ohio. My question is, and I think you answered it a little bit, but I'd love clarification. How many people have you detected to have this new variant or mutation? And also, is this detectable through a normal COVID test? So when you get the COVID test, is it a positive, negative? Are you able to also tell them that you have this specific strain or this new strain, and how many people, again, exactly have you?
Yeah, I'll answer the second question first, which is this is sequencing. So this is a special test that needs to be done, and the PCR test alone would not reveal the presence of these mutations, at least not with the current PCR test that we have. I'll comment briefly on the number of occasions. So in the case of the virus that has the mutation in common with the UK and South African strain, we have seen a single sample to date. In the case of the second finding of the virus with 3 additional mutations, we are up to around 20 examples of this in the samples that we sequenced so far. But as Dr. Muller mentions, we are now entering an era where we're going to be doing a lot more sequencing, have a larger denominator, and should be able to report in the next few weeks exactly what the percentage is to an accurate number in the Central Ohio area.
Thank you.
Let's go to the Ohio Capitol Journal, Jake Zuckerman.
Hi, thank you all for your time today. I want to ask, do you have any estimate on the R0 of the new strain in comparison with the old strains? And if you don't have a hard number on R0, can you give a sense of just how much more infectious this is, or is it just too early?
Yeah, it's too early. I think we will need several hundred isolates and better strain definition to be able to do an accurate calculation. It's a little anecdotal at this point, but obviously it's concerning when we see it 1 week having a single instance, the next week having 7 or 8 instances. That's a concerning trend, but we need to be looking at several hundred examples to really calculate that accurately.
And I would just add to that, Dr. Jones, that since the start of the pandemic, the Wexner Medical Center has developed labs that do just this, that look at the ability of variants to impact infectivity, and ultimately the most important question I think for all of us is, what is the impact on the patient? What is the impact on the treatment of those patients and their health? And that's something that is certainly critical as we look through the data going forward.
Yeah, that's an important point, that there are independent measures to look at transmissibility, and in vitro culture is one of them that we specialize in here, and it's something that could be supplemented to get additional data.
Let's go to Nick Evans from WOSU.
Good morning, y'all. How are you? Can you hear me okay?
Yes.
Good, good. Forgive me if you've already touched on this a little bit, but I'm curious, you've got the two different viruses here, right? You've got the one that mimics the stuff in the UK, and then you've also got this Columbus variant. You mentioned that there are 3 mutations with the Columbus variant. I mean, I am not a scientist coming to this, but to what extent do those 3 different mutations look similar to the mutations that have been seen in the UK virus? I mean, is there any sort of overlap or similarities between those changes?
No, there is one mutation that's in the same protein, the spike protein, but it's in a different area. It's not in the receptor binding domain of the spike protein. Instead, it's in an area we call the furin cleavage site, which is used to process and present the protein on the surface of the virus. So there is a little bit of data, experimental data, on the significance of this, but a lot more work needs to be done. It is in a conserved area of the virus, but it is totally distinct from the areas involved in the UK mutation.
Let's go back to Pete Grieve from Spectrum News. And he may not be able to get on the audio, but his question was, can you tell us how many infections Ohio State has sequenced or is sequencing per week of this variant?
So our surveillance strategy in December was only to do about 10 samples per week. We are now ramping that up considerably by orders of magnitude. So we'll be looking at hundreds per week.
Let's go to ABC, Sony Salzman.
Thank you. My question was answered. I believe my colleague, Dr. Llewellyn, has a question that he'd like to pose.
Okay, we have Dr. Sean Llewellyn from ABC News.
Yes, thank you for having me. So what do you believe are the pressures causing these mutations? Like, do you think it's from people who have been infected with COVID and getting reinfected and showing that the COVID is trying to escape from immunity, or is there another pressure within the environment that's causing these mutations?
Yeah, it's very interesting to speculate. As I mentioned, we're seeing it worldwide at the same period of time of the pandemic. One can think about a more evolutionary explanation in that just the number of human passages of the virus is approaching a point at which we may be starting to see optimization. But I think Dr. Muller has some additional thoughts on that maybe.
Yeah, and I would just add to that is we've seen in culture, and Dr. Jones knows this as well, where passage of certain viral strains creates specific variants or mutations. And so I think, again, it's still early days, but you know, when you not only think about this virus, but other viruses, they usually evolve very quickly to do things that are selectively advantageous. And in this case, what we've seen to date with virus evolution is that it may be to be able to stick to the cell faster or better, or be able to enter the cell more effectively.
Dr. Moeller, one of the terms that comes up in this is convergence evolution. Could you tell us what convergence evolution is?
Yeah, I think, you know, a lot of very fancy scientific words that we've talked about today, but just to take these sort of down a notch, to think about the virus in this case is working to survive. The virus is working to look for a host where it can stick around, and in this case, because we're dealing with so many people across the world, the virus has figured out a way to be able to stick around and reproduce. I do want to, because additional people have joined the call, is to make sure that people don't overreact to these data. What we have found today and what we are sharing today is the identification of 2 new viral strains. What does that mean? So it means that we want to have line of sight into where this virus is going. This is important for being able to create new diagnostics and new therapies. And it's also important to understand if the vaccine is going to continue to be effective. To date, we have no data that the vaccine will not be effective on these viral strains. And I want to continue to say that over and over. To date, we have no data that these viral strains will be ineffective for our current vaccines. The way that the vaccines are designed is to create epitopes that cover the entire protein of 1,300 amino acids, and here we're talking about 2 or 3 different amino acids. And so I can't overemphasize enough that we want to continue to understand the prevalence of these variants in the population. We want to understand the spread of these variants in the population from a public health standpoint, and then get these in the laboratory and date them for a few weeks to understand how do they behave, what are their likes, what are their dislikes, and making sure that we have the best data before we report it out to the world.
Let's go back to Leah Williamson from WTBN.
Yes, my question was just if this would raise any concerns about reinfection. If people already had it, they feel they're safe and can go out and about the rest of their life. Should they be concerned about possibly catching another mutation that would cause them to be sick again?
So as Dr. Mueller mentioned, immune responses to viruses, whether through vaccine or natural immunity, are very complex, and they produce antibodies against a wide range of different parts of the virus. And so single changes in the virus generally, by our knowledge in the past, do not lead to loss of protection against a related virus. However, this is the moment, as we're starting to see changes, where vaccination is being introduced and where the virus has been in the human population for some months, where we do want to be looking out very carefully for the emergence of not just single mutations, but new strains that have multiple mutations together. So the short answer is we have no evidence that a single mutation could lead to loss of natural resistance and reinfection. However, as the virus is changing, the risk changes as well.
That makes sense. Thank you.
Let's next go to Alex Stokes from Fox 8.
Hi, I wanted to ask about the efficacy you guys were just talking about of vaccination on these different strains. How, in the timeline of all of this, imperative is it to obviously get people vaccinated as quickly as possible? Would that curb in any way any more strains or mutations to help kind of kill this virus out in general, but also obviously from finding ways to survive?
I can comment generally. The less prevalent a virus is in the population, the less opportunity for new strains to establish themselves. I think, Dr. Thomas and Dr. Mueller want to talk about the general broad benefits of vaccination are far beyond that. But in terms of a selection point of view, the less virus, the less selection.
A great question, and in fact, our boss has an analogy that he uses of skiing in front of an avalanche, or skiing in front of a snow slide. And the faster we can get shots in arms, some of these questions become more academic than public health.
The one point I would want to add, I think was a question 2 questions ago, someone talked about if someone's had it, do they need to be more at risk of getting it again? just to remind folks that just because you've had the infection in the past, it is still the recommendation of the CDC, the NIH, and others that you get vaccinated. Even though we do think that having the virus in a natural way with infection does provide some immunity for a short period of time, the current sense of the science is that immunity from vaccination may be longer lasting and might be better. So please, just to make clear that just because you've had the infection doesn't mean you need to stop worrying about this permanently. It's maybe at best a 90-day protection. In some cases, it could be longer. In some cases, it could be shorter. But we still are recommending vaccination for those individuals.
Let's go to NBC, Akshay Sayal, and I apologize if I mispronounced your name.
No, that was perfect. Thank you, guys. Good morning. I just had a question about your one of the variants you had, the 677H. I guess my question is, do we have any sort of data to suggest that it's actually more transmissible, or could it simply just be due to this variant being at the right place at the right time?
So the lines of evidence we have in transmissibility increase relate to the change over the 3 weeks at the end of December and January. In terms of the experimental evidence of this change in the function of the virus, there's very little. It is within a conserved domain that is important for the recognition of the cleavage. So it is likely to have some impact, but we don't know whether that impact would lead to more transmissibility. These are things that can be studied in culture. They just haven't been done yet.
I think the only other thing I would add to that, Dr. Jones, is that similar to non-viral genetics, that it's important to understand variants in context. So a variant might change the parts of the structure of a protein, but if additional areas of that protein are mutated, then it might actually impact that variant itself. So it's important that we understand sort of the full zip code versus just simply understanding a single address when we think about what does a virus do. Is it more susceptible or not? Does it infect better? Does it cause more severe disease? So all of these things, it's simply not just one mutation or one variant. It's a variant in context with a lot of other amino acids and genetic sequence.
Let's go to Jade Jarvis, News 5.
Hi, I had a couple of questions about the patients for both the Columbus strain and also the new variant that was detected in Columbus. I know you were able to identify this Columbus strain through sequencing. For the patient who has the new variant, how were you able to pinpoint that one patient, and how are you going to, I guess, look for more patients who might have contracted this new variant? And also, do you have any information about the travel history or any additional information without identifying them for either the strain or the variant?
Right. So this study is a surveillance study looking at general across the board PCR positives, and most of these patients, as in the patient that was positive for the UK mutation, are for admission into the hospital or one of our clinics. So what we know about this patient is an elderly woman who was screened for admission, and that's basically as part of the study. We don't go into great details on the particular patients. Now, in terms of how to identify this going forward, well, obviously we're taking a very broad approach and looking at a lot of positive samples, but there is some suggestion from some other variants that you may be able to do it by how positive the PCR is in the initial test. So we are actually looking at that issue now and seeing if that's helpful in identifying which patients we should sequence going forward. So right now it's a broad approach, but we may be able to identify features of the PCR test that help us to decide which patients should be sequenced.
Okay, let's go back to Melissa Voetsch from 13 ABC.
Hello. When they announced, the UK variant was starting to be discovered in different states, they said it likely has been here for a while and it's more widespread, at this point, if we're now detecting it. This particular variant was discovered in the Central Ohio area. Is it assumed that it is in other parts of the country? And, how will that impact our knowledge about this?
Yeah. So the short answer is we don't know at this point. It's a new finding. We will be in our preprint. We will be including the sequence of the virus so other investigators across the country and across the world can see whether they see this in their set of sequence. My guess is we'll get some data pretty soon to address that question.
And the only other point I just want to clarify with the question is the strain that was identified by Dr. Jones's lab is not transmission from one of those UK strains. This is an independent mutation that came about on a strain that is existing in central Ohio. So it's not that someone traveled and came to, this is a variant on top of a backbone that was in central Ohio, not a transmission from a UK carrier of one of those states.
Right.
As we finish up, I just have one last question of my own for Dr. Jones. Is there any concern that these variants that you've described today will be picked up just as easily with PCR testing or the rapid testing? Are they able to be identified with our current testing?
Yeah, that's always an issue. And when multiple parts of the virus change simultaneously, it raises the potential that PCR tests might become less effective. That specific issue we're actually looking at right now as we speak, so we should have an answer to that shortly.
Dr. Allen, just to add one point to that, when we at Ohio State do the amplification for the PCR for COVID-19, we actually look at 2 or 3 different target sequences. One of this might be affected, but the other 2 are still there. So if we get inconclusive results from a PCR test, we just reanalyze them again with other primers.
Let me thank today's panelists, Dr. Andrew Thomas, Dr. Nicholas Kaman, Ryan Haley, Dr. Peter Moeller, and Dr. Dan Jones. And I'd also like to thank each of you from the local and national media for the role that you're playing in keeping the people of Central Ohio and the people throughout the United States up to date on the COVID-19 pandemic. We'll be back next week to talk more about the latest news in COVID-19. And until then, please wear a mask, practice hand hygiene, and please promote vaccinations.